Okay, we want to pick up with our discussion of the circulatory system and our discussion of blood with our next class of formed elements, and these would be the leukocytes or the white blood cells. And they're primarily tasked with defending the body against disease. They also remove dead cells and debris. They can move in and out of the circulatory system at will as a result of amoeboid movement. Remember, this is facilitated by cytoskeletal components and a phenomenon that's known as chemotaxis, the ability to move towards a chemical in a liquid environment. This is one of the very earliest examples of what we would eventually go on to describe as a nervous system in more advanced organisms. This is the ability uh, to essentially move towards components in the environment that will aid in your survival and away from components in the environment that would likely kill you. So we call that positive and negative chemotaxis. Here it's used to facilitate the movement of white blood cells towards areas of infection. Diapedesis is where the cells become thin, they elongate, and they move either between or through the endothelial cells of capillaries. They're able to change their shape in dramatic fashion in order to do this. And chemotaxis, of course, is, as we simply described, right, the movement of these cells towards a particular chemical component. In this case, there are components that are secreted by damaged tissue at the site of an injury that serve to call or bring these white blood cells to the area where they're going to do the most good. What happens once they arrive is that they do battle with the pathogens and they remove dead or damaged tissue. Um, the result of this is that certain cells die. This accumulation of dead white cells in the course of fighting the infection and removing the cellular debris we call pus. So let's take a look at the granulocytes. Remember, the granulocytes are part of our nonspecific defenses in that they use the same chemical attack regardless of the identity of the pathogen. And they're named granulocytes because they have visibly staining granules in their cytoplasm. And the first granulocyte we want to talk about is the neutrophil. After leaving bone marrow, they usually stay in circulation about a day. Then they move into other tissues, become motile, and they phagocytize bacteria and antigen antibody complexes and foreign matter. They also secrete lysozyme, which is an enzyme that cleaves certain covalent bonds in bacterial cell walls and makes them susceptible to osmotic shock. They last for about 2 days and they account for about 70% of the white blood cell population, so they are the most abundant of the leukocytes. The eosinophils have red staining granules in their cytoplasm and they leave the circulation in inner tissues during inflammation. They are prevalent in allergic reactions where they phagocytize antigen antibody complexes. They destroy inflammatory chemicals such as histamine and release chemicals that destroy parasites such as tapeworms, flukes, pinworms, and so on. And they account for about 4% of the circulating white blood cells. The basophils are the least common of the white blood cells. They leave the circulation and migrate through tissues. They're important in the inflammatory response because their blue staining granules contain large amounts of histamine. In addition to that, they also make heparin, which is an anticoagulant, and they're about less than 1% of the total white cells in a normal individual. Lymphocytes are part of our specific immunity. So when we talk about lymphocytes and monocytes, we're really talking about a whole other arm of our immune system that defends us against disease by sculpting a chemical attack specific for a particular pathogen. Lymphocytes are produced in the red marrow, but then they migrate to the lymphatic tissues where they proliferate. They're responsible for antibody production. They've been studied extensively in the immune system. They come in two flavors, the T lymphocytes and the B lymphocytes. The B lymphocytes are the antibody producers, while the T lymphocytes come in three classes, the helper Ts, the cytotoxic Ts, and the regulatory Ts. The helper Ts facilitate the reproduction of B cells and cytotoxic Ts. the regulatory Ts serve basically as an off switch for the entire immune response, and the cytotoxic Ts actually show up where infected tissue or pathogens are located and destroy them chemically, either by punching holes in the cell membrane or by secreting chemicals that cause the pathogen or the infected cell to commit suicide. Monocytes eventually become macrophages, and they work in tandem with lymphocytes as antigen presenting cells. Essentially, they engulf pathogens, lysosomes fuse with these endosomes, cleave the pathogen into little tiny bits, and then portions of the pathogen are presented on the membrane surface as a warning to the rest of the immune system that there's a pathogen inside the body. The lymphocytes that are able to recognize, i.e., bind to that pathogen and be stimulated to divide, are going to be those chosen to go out and fight the battle against this particular invasion. This is important because instead of having all white cells reproduce, we select only those that are going to be able to recognize molecules that are on the surface of either an infected cell or the pathogen itself, and as a result, the attack is much more targeted. Okay, but these two systems work together. The granulocytes, along with your external barriers, your mucous membranes, your skin, the antibacterial secretions in those, and also the granulocyte activity, they sort of serve as our first line of defense. And then in the event that something penetrates those defenses, what happens is that the immune system is there to intercept any invaders that may have slid through. The platelets are involved primarily in promoting the coagulation of blood. These are cell fragments that bud off of megakaryocytes that are found in the red marrow. They have surface glycoproteins that allow adhesion to molecules like collagen, and they're vital in preventing hemorrhaging. Okay, so they're involved in the process we call hemostasis. They form platelet plugs that are essentially a temporary seal between the inside of the body and the outside world at the point of the injury, and they promote the formation and the contraction of the clot. The clot is essentially a meshwork of protein and dead cells such as thrombocytes and red cells and white cells that become enmeshed in this mass of protein that serves again as a temporary seal between the inside and the outside of the body, providing time for the immune system to battle the pathogen, and in addition to that, for tissue repair to take place. In the event that the platelets malfunction or the individual is missing a clotting factor, one of the things that can sometimes happen is a continued hemorrhaging, which we categorize as hemophilia. Some people are born with a defect in one of the plasma proteins that promotes the clotting reaction. The result is that they would continue to hemorrhage if they weren't supplied with the missing clotting factor, and that's exactly how we treat this disorder. Hemostasis in general is simply the arrest of bleeding. These are events that prevent you from hemorrhaging out. One of the first things that occurs is a vascular spasm where we have vasoconstriction near the site of the injury to prevent excessive bleeding. It's caused by the release of thromboxanes from platelets and endothelin from the damaged endothelial cells. At any site, like a puncture or a cut or an abrasion, you're going to have damaged endothelial tissue, and the result will be the release of these chemicals. Then you'll have platelet plug formation as thrombocytes cling to these exposed areas. You could think of these molecules as sort of sticking out in the blood supply, and the platelets, as they pass by, they attach to these sticky areas and release clotting factors. Coagulation is the next process, and that's basically the conversion of fibrinogen to insoluble fibrin, which then serves to trap cellular debris and also to serve again as a plug that is going to keep you from continuing to bleed out. This is just a look at an actual blood clot. You can see the fibrin, you can see the red cells and the platelets enmeshed in this network. There are several stages of this process. First is the activation of prothrombinase, which converts prothrombin to thrombin, which in turn converts fibrinogen into the insoluble fibrin. Those are really the last three steps of the clotting cascade. There's several factors that are activated upstream of this that constitute an extracellular cascade. Okay, and remember, we talked about the fact that the purpose of a cascade is to take a tiny stimulus and magnify it so that we get a rapid and large response very quickly. But the other benefit of a cascade system is that it's easy to turn off. Coagulation factors are proteins that you find in the plasma, and they circulate in an inactive state until tissues are injured or until blood flow slows sufficiently, at which point spontaneous clotting can occur. The damaged tissues and platelets produce chemicals that begin the activation of these factors. There are two pathways. There's an extrinsic and an intrinsic pathway that both end in the same place, the production of a fibrin clot. And this is essentially an insoluble proteinaceous mass that serves to trap blood cells, platelets, and some fluid, and serves primarily as a seal while the work of battling the pathogens and repairing the tissue goes on. So this is just a look at how platelet plug formation occurs.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A in combination with 5A activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot. It can be concluded that the central role of factor 10A in the coagulation cascade makes it a viable target for therapeutic intervention in pathologically altered blood coagulation.
Okay, this is just a look at all the clotting factors. Look how many there are, okay? The point of having so many factors is that you have a relatively extensive cascade system that works in the extracellular environment. This is what allows us to magnify the stimulus from the initial injury into the final response, which is the production of this insoluble clot. Any of these that are missing are going to result in a lack of the ability to coagulate. And so again, we fix that by providing the missing factor. Most of these genes, in fact, I believe perhaps all of them, are on the X chromosome, which means that it's more common in men to have this problem, hemophilia, than in women, because the missing factor would essentially be a recessive disorder. And so in males, you only need one defective copy of one of these clotting factors genes on the X for the bleeding phenotype to show up. Whereas in women, since they have two X chromosomes, you would need two defective copies of the X. So how do we control clot formation? Well, anticoagulants prevent coagulation factors from starting clots where we don't want them to happen. Coagulation is initiated when a coagulation factor concentration exceeds a threshold, for instance, at the site of an injury. Okay, this is one of the places where they can transiently concentrate and initiate the formation of the clot. The other place this can happen is any place where blood flow is slowed, and this is one of the reasons we worry about things like deep vein thromboses, where as a result of lack of movement and blood becoming static in the lower limbs as it tries to move up to the heart against gravity, you can spontaneously clot. And if those clots travel to a capillary, say in the heart, it could cause a coronary, the brain, it could cause a stroke, or it could cause a pulmonary embolus in the lungs. Okay, so one of the reasons we encourage people to move is to avoid this kind of stuff. Venous stasis is a dangerous situation. Anticoagulants that circulate to essentially undo this process or keep it from spontaneously happening include antithrombin, which is made by the liver and slowly inactivates thrombin, and heparin, which is produced by basophils and endothelial cells, and it increases the effectiveness of antithrombin. Prostacyclin is a prostaglandin derivative from endothelial cells. Remember, these are derived from free fatty acids, and they promote vasodilation and inhibit the release of coagulating factors from platelets. And so we kind of have to keep this clotting cascade in check because we don't want it to launch inadvertently. The other thing that, of course, happens is that after the clot has served its purpose, these factors will aid in preventing further clotting, and in some cases, as we're going to see in a bit, they'll actually eventually dissolve the clot. So this is a look at what happens after the clot has served its purpose. In fibrinolysis, what happens is that plasminogen is converted into plasmin, and what happens here is that this is sort of an outcome of factor 12 and TPA and other enzymes such as urokinase. The active plasmin will then dissolve the fibrin clot after it's served its purpose, after we've repaired the tissue and we've fought off the pathogen. So it breaks down the fibrin molecules, the clot becomes essentially fragmented, and then is washed away in the blood, and some of the fragments will end up being phagocytized. Another thing that sometimes happens when we hemorrhage is that we need blood from another source, and the way that we do this is through transfusion. But in order for a transfusion to be successful, we have to have a match between the donor and the recipient, and there are certain rules that govern which blood groups can accept which kind of donor whole blood units. Transfusion is simply the transfer of blood or components from one individual to another. Infusion being the introduction of fluid other than blood. Sometimes, for instance, we'll give infusions of plasma or even saline in order to get blood volume and blood pressure back up. The compatibility of blood groups is determined by antigens on the surfaces of the red blood cells, and these are called agglutinogens. Agglutinins are the antibodies that recognize and bind to these agglutinogens. So those are two very similar sounding words. Don't confuse the two. When they're active, when these antibodies recognize their target antigen, they'll spur the clumping of red blood cells, and this can ultimately result in their rupture. We call that hemolysis. And the thing that's dangerous about that is that when red blood cells rupture, they release hemoglobin into the plasma, And hemoglobin, while it's a great molecule for transporting oxygen in the context of a red blood cell, it's a dangerous molecule to have floating free in the plasma, okay, because it can block capillaries and cause all kinds of other problems. The main antigen groups are the ABO and the RH groups, and we'll talk about each of these here in this video. We'll talk about the ABOs, and then I'll address the RH groups. So take a listen.
Type 2 hypersensitivities involve interactions of antibodies and surface antigens of cells, followed by complement-assisted lysis of these cells. A typical example is mismatched blood transfusions. There are 4 different blood groups based on types of antigens on the surfaces of the red blood cells. People who are type A have A antigens, and those who are type B have B antigens on the surfaces of their red blood cells. Persons who are type AB have both A and B antigens, and those who are type O have neither A nor B antigens. The serum of people with type A blood contains antibodies against type B antigens, and the serum of people with type B blood contains antibodies against type A antigens. Type AB serum contains neither antibody, and O serum contains antibodies against both A and B antigens. If blood from a person who is type B is transfused into a person who is type A, antibodies present in the type A blood react with the surface antigens on the incoming red blood cells. This leads to complement fixation and lysis of these cells. If blood from a person who is type A is transfused into a person who is type B, antibodies present in the type B blood react with the surface antigens on the incoming red blood cells. This also leads to complement fixation and cell lysis. Persons who are type O lack A and B antigens on the surfaces of their red blood cells and are therefore universal donors. Persons with type AB blood lack antibodies against A or B antigens and are therefore universal recipients.
Okay, so based on the information you've just heard, understand that type A blood has anti-B antibodies while type B blood has anti-A antibodies. It's suggested that these antibodies are present because of exposure to A and B antigens on bacteria or on food. The donor gives the blood and the recipient receives it. Type O is termed universal donor and can actually sometimes cause transfusion reactions because of antibodies in the O blood plasma. But when we collect blood, what we do, like when you donate at Hawksworth, is that we actually remove the donor antibodies from the whole blood and resuspend the packed cells in saline, and those are the units that are given to patients. And so we never have to worry normally about the donor's antibodies and the recipient's antigens. We only have to concern ourselves with incompatibility between the donor antigens and the recipient antibodies. So that's what determines which blood types can receive which other blood types. Okay, as an example, right? Type A blood can receive A blood or O blood. Type B can receive B or O. Type O can only receive O, and type AB can receive any of the blood types. Now there's another there's another group, blood group, antigen group we have to concern ourselves with, and this is the RH blood group. It was first studied in rhesus monkeys. That's where it gets its name. And there are 2 types of RH antigen presentations. Okay, there's RH positive, meaning that you have these antigens on your surfaces of your red blood cells, and there's RH negative, where the antigens are not there. In an individual who's RH negative, they will only generate the RH positive or the RH antibody in the event that they're exposed to the Rh antigen, either as a result of a transfusion mismatch or in the case of a pregnant mother when when an Rh positive baby is born to an Rh negative mother and the baby's blood and the mother's blood temporarily mix at birth, and that constitutes an exposure. Hemolytic disease of the newborn is where we have an Rh positive fetus in an Rh negative mother. Late in the pregnancy, the Rh antigens of the fetus cross the placenta through a tear during delivery, and the mother creates anti-Rh antibodies as her primary response. A second Rh positive pregnancy can initiate a secondary response that can be fatal to the fetus as these antibodies cross the placenta and get into the fetal circulation. They can hemolyze the blood and potentially kill the baby. The reason we don't worry about this anymore is because we've invented a drug called Rogam that is a cloak for the Rh antigen. And what it does is it disguises it from the mother's immune system, and the result then is that she never actually has an exposure. Okay, so you give this before, during, and after the potential pregnancy of an Rh positive child. Before this happened, we had to do what we call blood tests, where we had to check the Rh compatibility of the husband and the wife, and then based on the results of those tests, that would inform their decision whether or not to get married and have children. And so this is just a look at how erythroblastosis manifests itself. So before or during delivery, Rh positive red blood cells from the fetus enter the blood of an Rh negative mother at a tear in the placenta, and that happens at birth. The mother is sensitized to the antigen and generates antibodies. Because this usually happens after delivery, the fetus is not affected in the first pregnancy. So the first pregnancy will go off generally without a hitch, unless something very unusual happens, such as that mother had received a transfusion of Rh positive blood at some point in her life. What will happen next is that if there's a subsequent pregnancy with an Rh positive child, then the antibodies that are already present can cross the placenta and enter the fetal circulation. And what will happen is that those antibodies can then hemolyze the red blood cells in the growing fetus. So as they cross, they can trigger agglutination and hemolysis of the fetal red blood cells, and this will result in hemolytic disease of the newborn. Now, we do have methods to try and rescue the baby in the event that this occurs. There are certain treatments that can essentially try to stanch this hemolytic reaction, but the best approach is to try and avoid the situation to begin with. Okay, so when we have somebody who needs blood, one of the things we have to do before we find them whole units is we have to do a type and a cross match where we determine their ABO blood type and their Rh type, and this is done by testing their red cells against antibodies of a known specificity, and then we determine their blood type, and that'll dictate what type of blood we can use as a donation. A complete complete blood count is where we work up the red count, which is the number of red blood cells per microliter of blood, so that's your hematocrit. And then we can do hemoglobin measurements, which are grams of hemoglobin per 100 milliliters of blood. On average for a female, that's 14 to 18. It's 14 to 18 for a male, and for a female, it's between 12 and 16 per 100 mils. This difference is the result of one hormone, okay, primarily, and also menstrual loss. The hormone, of course, is testosterone. Okay, so let's write that in here real quick. And we'll do that in blue. So, well, here we go. T E testosterone for short. Put a little period there. A hematocrit is the percent of blood that is RBCs. So when you do a red count and a hematocrit, you're kind of doing essentially the same measurement, just with different processes. The red count would it be an actual, you'd actually examine the blood, you'd count the cells, say under a scope. Hematocrit is where you pack the cells after you spin them down in a centrifuge and look at the volume of red cells versus the volume of whole blood. And so what it'll do is it'll separate into a packed column. Okay, that lower portion would represent the crit, and then you'd have a buffy coat where the white cells and the platelets are located, and above that, of course, the straw-colored plasma. The white count between 5 to 10,000 per microliter of blood is typical of an individual who's healthy. It'll rise in the event of infection, okay? And with the white count, we can even go further and sometimes do what we call a differential count, which we'll talk about in a bit, where we look at changes in the proportions of the granulocytes compared to what we'd normally expect, and that can be an indication to the clinician as to the nature of the disease. And so this is just showing you how you do a hematocrit. You simply do a finger stick, and then you bring the blood up in a capillary tube. The blood will be attracted to the glass of the capillary tube and will wick up to the top of the tube, and then you plug both ends with clay, and then you spin it in a microfuge, and then you end up determining now the percent of whole blood per volume, or the percent of packed red cells per volume of whole blood. So when we do a differential count, what we're looking at is the percentage of each of the five types of white cells. Normally, we have the following percentages, right? Neutrophils, lymphocytes, monocytes, eosinophils, and basophils, in order from most to least abundant. There's an acronym to allow you to help remember this. Never let monkeys eat bananas, okay? From most to least abundant when we're looking at the leukocytes, okay? If these ratios are disturbed, if they are outside the norm, then that can indicate some type of disease state. For instance, if you had a high neutrophil count, we might expect a bacterial infection. If your eosinophil count was elevated, we might expect an allergic reaction or a parasitic infection. Just a couple of examples. Clotting is determined with the platelet count. The ability to clot is a measure of your blood's ability to prevent hemostasis. Normal platelet count is between 250 to 400,000 platelets per microliter. If you've ever seen a platelet under the scope, as we saw earlier, they almost don't look like anything. You would think that they were debris. Okay, they're so small. But those are, in fact, anucleate membrane-bound sacs of clotting factor. Prothrombin times measure how long it takes for the blood to begin clotting. On a normal individual, it's 9 to 12 seconds, and to test this, thromboplastin is added directly to whole plasma, and then we measure how long it takes for the insoluble clot to develop. Blood chemistry is simply a measurement of the materials that are dissolved or suspended in the plasma, and it's used to assess the functioning of a lot of different body systems, not simply the circulatory system. So there's certain things that we expect to find in blood, and there's certain levels we expect them to be at, and then if those levels shift, then we worry. One example might be, let's say that you took a blood sample and you found that the blood urea nitrogen was abnormally high, okay? And what that might tell the clinician is that the kidneys are beginning to fail, or that there's something impeding their function. And this is just a look at some of the different conditions and descriptions that are associated with the blood, okay? The clotting disorders, things such as anemia, erythrocytoses, and infectious diseases of the blood. So star this, know this material. This will be important in PRS quiz, and I will see everybody in class. Thank you very much.